And thank you to all of you for inviting me to speak on this again, because I did a similar talk, and probably quite the same as last year, but there are new things. So this year, a little bit more philosophical to start with, is exercise medicine? Those are my disclosures, so we'll move on. So the answer is yes, obviously. And just, as every self-respecting clinician and anybody, I looked up ChatGPT to see exactly what they said. And they said, of course it is, because it was a term that was sort of popularized by the American College of Sports and Medicine and the American Medical Association to encourage physical activity for prevention and treatment, because it encompasses the key aspects that you would want out of any treatment intervention. So it prevents chronic disease, it improves mental health, and that's particularly important in advanced breast cancer. We've got evidence for that. Reducing stress and improving anxiety and depression. It manages existing conditions, i.e. advanced breast cancer and various other conditions, obviously. And then the key thing, which is vital for any therapeutic maneuver, is that there is a dose-response relationship. So what we're trying to do when we look at exercise as medicine is to say, what do we need to do? What do we need to prescribe to have an effect? This sort of slightly wishy-washy, we'll just exercise. We do need to come up with a prescribed program. So that is the philosophical bit out of the way. And I will cover some key issues. So I'll just go through the rationale for use of exercise in advanced breast cancer. What's the evidence to date? What's the current research? And what actually can we implement from now without having to wait for further research? So whenever I sort of talk about this, I get this kind of, oh gosh, it can't be for me. All this stretching and bending and jumping around and throwing yourself at things. It's just not what I should be doing. I really don't feel like doing it. And that is very understandable. A lot of my patients say exactly the same thing to me when we even start to broach the idea of exercise. But actually, there is a little bit more to it than just what you standardly understand as exercise. So just before we start, I'd just like to just get an idea of how many of you are taking any form of regular muscular resistance exercise. Well, that's really impressive. So that is things like yoga, Pilates, and stretching exercise with weights. And that's the key thing, with weights. It doesn't have to be huge weights, it just has to be weights. So that's very reassuring. And then this is often the worst bit, is how many of you have actually had a decent conversation with your physician about doing exercise, where you felt the physician actually had any idea? No, and that is the biggest problem. It's not, exercise as an adjunct to any of your discussions with patients across all specialties is not taught very well in medical school. It still isn't taught very well. It's supposed to be the domain of the other person, whoever that other person may be, and actually it's a failing of the medical establishment to say, no, this is actually bread and butter prevention for all forms of disease and treatment in all forms of disease, including cancer. And in cancer medicine, we're getting there, but particularly in advanced cancer, we're still way behind. And today I'm hoping to tell you that this is now really being questioned, and you can implement some form of exercise. So I think the take home, if there is a very simple take home, is controlled and moderate is actually appropriate and should be done regularly. And why are we even thinking of exercise in advanced breast cancer? Because again, we're the nihilistic population outside of our realms. They don't understand that breast cancer actually is a chronic disorder for many of you ladies. You're living with this for a long period of time, hopefully, and we have had introduction of new drugs that have meant that the progression-free survival, the time before you next relapse, whether it first time or second time, is getting longer and longer. And there are lots of relatively well periods where we can actually look towards other behavioural interventions to assist you in how you overcome your symptoms and deal particularly with your treatments. So as I said, that just exemplifies our prevalence in Kent. We as Carlo, who's an expert in this area of collecting data on advanced breast cancer, we know that it's very difficult to collect data on advanced breast cancer because the way our collection tools are geared, they don't pick up advanced breast cancer very well. We've just done a huge national audit where essentially the data is pretty useless because it's not collecting the patients that we want. It's collecting an adjunct of something else, and it's not really reflective. So most of us try and collect our own data, and we know, and we can tell government that actually the prevalence, which is really reassuring, i.e. the number of patients on our books, like yourselves with advanced breast cancer, is growing exponentially because patients are living longer. So as I say, they're living longer with advanced disease with relatively controlled toxicity from treatments. Obviously, we know there are some treatments that you're taking that can be very hard, but again, the exercise is there to actually help that. So what's the standard rationale for exercise? Well, it's this combination of the physiological and the psychosocial. And obviously for breast cancer, a lot of the psychosocial side is is understood, and even the physical sides are quite clear. Cardiovascular with some of the drugs that you're taking, some of the interactions with other medications can cause changes in the motor side, so that exercise can help this. And the standard effects have been that have been really attributed to in early disease, but in other chronic disorders they're well recognised. And the main importance is in muscular wasting, and it's the concentration on lean body mass. So lean body mass is slightly different to BMI. You can actually have what seems like a relatively high BMI, but your lean body mass, by virtue of doing muscular resistance training, can actually be good. So you have a good musculature. So it's all about being fit and not concentrating on fatness. So you may still have topical fat, but you have a lean body mass. And that's, I think, very important to understand, because often you carry over an inherent fatness habitus, but actually you can still train your muscles, and that's very important. So why is it important? Because sarcopenia is an objective issue. Sarcopenia is muscular wasting, and that's a quantifiable issue which is known to be associated with advanced cancer, and it's known to be associated with poor outcomes a lot across many disease groups. So that's not just cancer, but particularly, obviously, for cancer is really well known that it's associated with poor outcomes. So we are concentrating on trying to improve your muscular power, okay? And that is where muscular resistance exercises come in. And they are very different from the other type of jumping around and bouncing around that is really annoying, quite frankly, and wearing lycra and, all the rest of it. So there still is, there's been a lot of advice to date about fatigue. It's in all the guidance about fatigue. That's quite clear. So contrary to the view when you're feeling absolutely exhausted after your treatment, and those 2 or 3, sometimes a week, sometimes longer, if you can, that's a lot of it's associated with change in metabolic rate, particularly chemotherapy. It's an absolute thrashing to your body. Your body goes, oh God, no, I'm shutting down. I'm just shutting down. And you go into a slow metabolic rate. If you can, through muscular resistance, con your body that actually you can pick up your metabolic rate, it overcomes the fatigue. And that's a rule of thumb that works through all disease groups and early and advanced disease in all cancers. So it's actually just rejigging your metabolic rate. So it's in there for fatigue quite clearly. It's been long established, but again, not spoken about very well by medics. So in the NCCN guidance, it's in there, and it's in the ESMO guidance as well, and that hasn't changed. And what about around the world? Well, a lot of the foundations do talk about this. The New Zealand Breast Foundation talks quite clearly about advanced breast cancer and the benefits of exercise and muscular resistance training. Fatima's group, the Advanced Breast Cancer Group, in their annual reports, the ABC 6 says exactly the same as it says in 5, which is that there is evidence for exercise, both aerobic, and they put in the World Cancer Health Forum advice, which is 3 to 5 hours of moderate walking per week, improves quality of life, cardiorespiratory fitness, physical performance and fatigue, and may also improve DFS and overall survival. So that's the key thing. In early breast cancer, we're virtually there on proving that. In advanced breast cancer, we're not quite so closely there. But we're working on it. We cannot believe that increasing improving the sarcopenia through the correlate with sarcopenia and poor outcomes won't actually help long-term outcomes. So that's the drive. NICE, of course, is pretty useless. Always about 10 years behind time, and takes about a year to get a group together, another year to decide what the remit is, and another 4 to write the report, and then it's out of date. They do at least refer to some of the guidance that is on the NHS website, which is at least something, because there is actually, as I'll go through, some quite good advice on the NHS websites. And it talks about, obviously, healthy weight gain and obesity and the need to various other health and lifestyle manoeuvres, and talks about exercise really for early breast cancer, but consigns exercise for advanced breast cancer into research. And there's no change on that. I've looked at it again, and I can't find any further reflection on the use of advanced breast cancer, use of exercise in advanced breast cancer. So, just to now look at the background regarding the problem related to is evidenced from early breast cancer. So, there's a sort of a mantra that the weight gain, the obesity, the loss of muscular lean body mass is related to diet, is related to exercise, and things clearly like 2/3 of early breast cancer patients have a body mass index of greater than 25 at diagnosis, and that there's a clear correlation between overall survival and your BMI, particularly with ER positive breast cancer, and that obesity increases DFS events and reduces overall survival in HER2 positive, for example. And the same is seen as triple negative, with weight gain and distant recurrence in all tumour sites. So there's clear evidence of certainly a weight gain and body habitus, which is where the idea of exercise came from early breast cancer, and certainly the observational studies in early breast cancer, most of which are retrospective, but the starred ones are prospective, show that there's clearly a risk reduction when you control for weight and by inference, by utilising exercise in part to do that. So one of the early breast cancer studies presented a couple of years ago and soon to be published was looking at using health coaches with quite, the World Cancer Foundation's 150 minutes of physical exercise up to 225 minutes maximum with and their goal was 10% weight loss, and it just shows you how hard it is to do, because they only achieved a 5.6% weight loss with endocrine-only patients with a large BMI, and a lot of people withdrew. These are all American patients, so and they had a lot of problems through that study. So they are difficult studies to do, but there's evidence by doing any of this that you do get with resistance training, particularly in early breast cancer. Chemo completion rates are improved, lean body mass is improved, muscular strength is improved, and self-esteem. So this is where you start to add in this muscular resistance and you get a slightly better outcome. So what about the evidence in advanced breast cancer? Well, in Manchester, I've just spoken to Sasha actually, because I couldn't see what had happened to the study. The BEAHEAD 3 was one of the first studies in advanced breast cancer conducted by Michelle Harvey's group at Manchester. And it really was a concerted effort to do a diet restriction and exercise study in advanced breast cancer. And it was a hard study to do, and they only recruited half their patients. And they utilised this platform called Physiotech, which is a platform of many, many exercises, but there are limitations to it, and it's really been written for orthopaedic rehabilitation. It's got very good videos, but no voiceover, and the habitus of the patients is clearly has no correlation to anybody who has cancer. So it just is not particularly useful for cancer patients, I would say. So there's also other evidence that hasn't quite come out to full publication yet that there's improvement with aerobic activity in both fatigue, pain, and quality of life. But quite small studies. The early feedback from the Be Ahead study was, again, as I said, just quite difficult to do. Less than half the patients, I think they got 50. This was the first presentation, and quite a high dropout rate. And although they wanted people to stay on study for longer than the 6.8 months they got, that's what they got. But there is one very good and the largest randomized study done to date, and that's done by Anna May from Scandinavia. And she's done a lot of work in this area, and this is called the Preferable Effect, which was published last year. And that is the key to all these things, is supervised activity. So it's a question of how much supervision you need to get the effect you want, and what health systems can actually do that. And that's the trouble for us in the UK, is our health system, it's really a nice to have. I mean, certainly now it's going to be really a nice to have, which is the problem. But these studies rely on supervised activity intervention. And this is mostly done by physiotherapists. And of course, physiotherapists are not to a penny in the UK. They're extremely rare. They're pulled from pillar to post, as we know. And actually, you don't need a physiotherapist. You need a physical expert, a physical therapist. And physical therapists should be trained to do this type of work. And it's really quite sad, because we've got a very large school of exercise medicine and sports science in Kent, and they put in for a course to train for physical therapists, and it got turned down by the university's body. So that's how important we think physical therapy is in this country, and that was supposed to be utilised across all health groups. So we talk a good story, or government talks a good story, but it's very lacking. But I would imagine that you ladies are champions of various issues. That's why you're here. And I think probably we're going to have to get patients to be involved in championing in their own areas, asking for the physiotherapist to get trained and working through that way, or volunteers. There are plenty of people who know people who want to do this, and we're going to end up having to do that, because we're not going to get any support from the government. It's not going to be forthcoming. There just isn't any money left. So I think we're probably going to have to look at other ways. However, this did show that with patients who, they were quite highly motivated, they were quite high educationally active. They were 74% of them had degrees. They were married, BMI greater than 26, average 55 years, and they were receiving first and second line treatment. And the intervention was aerobic, moderately high intensity, and again resistance balance training. And the intervention was for 9 months, and they had a pretty good turnout. And 18% discontinued at 6 months and 24 at 9 months. But they did achieve statistically significant low physical fatigue, which is really important, and again, improvement in quality of life, pain and breathlessness. No effect on emotional fatigue, and I think that's really quite interesting, and I think that shows how much probably we have to introduce other forms of CBT or psychological counselling to go along with exercise for the emotional fatigue, because I think that's often very underestimated, and probably there's a parallel thing that needs to go along, and I think you will no doubt feel that yourselves, and have evidence for that. So as I said, most of this work has been done on changes in BMI, but we really are more concentrated on lean body mass because of this objective goal of sarcopenia improvement, and we can measure that using DEXA scans. And then we also have these biometrical impedance devices that show a correlation with DEXA, so they're another way of doing it. But again, it's, to actually utilise this from the get-go now, to say, right, do that, and then we'll measure your DEXA. We can't do that in our health economy. And, there's still a little bit concern about what patients can and can not participate. So just a little bit on lean body mass. That is the purpose of resistance training, and that's really my remit today, is to get across to you is about resistance training. There's various ways to, there's these resistance biometric devices, and grip strength actually is quite a good correlate with muscular improvement. And you can also do it by CT scan. So there is a possibility that you can incorporate this into your 3-monthly follow-up scan. And it isn't too difficult to look at psoas, particularly that muscle, that big long muscle that runs down your back, to look at the change in the psoas size with a regimen, with a prescribed exercise regimen. So just going back, we know that the problem for advanced breast cancer patients, and this is an Australian study, and there's a guy called Rob Newton who has got basically an exercise study town in Perth, a mini town. When I went out to Australia a couple of years ago, I was trying to get out there, but he said, well, you turn left at this intersection, and then you'll see our campus. And he's basically got a whole campus where he does all this work with different tumor types. But they've seen that aerobic activity is really hard. So all that running and jumping that I talk about, that is hard and is off-putting, and the adherence is rubbish. So I think keep it simple, and as I say, it's resistance training. So current research, there is a group called the Safe Fit group down in Southampton. They're trying to look at multimodal intervention to improve both psychological and physical well-being with all forms of cancer, advanced cancer. It's a randomized phase 3. It's going very slowly again. And they're looking at trained personnel. That's the limitation. That's the difficulty with funding. Nutritional support, as per the WCRF guidance, which the World Cancer Research Foundation. Psychological support as well, which I think is really good, because that's, as I say, paralleling the idea of physiological betterment, but with psychology to help. And then the physical activity is in there with aerobic and resistance training. So they are quite keen on a process that's quite safe, and we'll go into that a little bit at the end. So in Kent, we actually thought we'd try and start again from the beginning and to look at what's available out there in terms of these prescribed exercise programs that are online from like Physiotech, because patients were saying, it just doesn't appear that they could do these things. They just don't look like people like them. So, we thought we'd address this, and we wanted to produce a video with a sort of prescribed exercise program that was devised by the people at the School of Medicine, a School of Exercise and Health Science. And we also wanted to incorporate an online platform, because I think, the reality of actually doing an in-person session is limited. Again, resource implications, and actually people being able to give the time. So I think we've got to be able to build in, even though you may get an introduction to exercise, that you can take that home and do it at home. So we wanted to improve the acceptance and adherence of exercise, and produce a video product for future validation in studies. That's what you have to do with these type of behavioural studies, is you have to actually show that what you're going to do is going to be accepted. So the intervention is actually baseline accepted before you actually try and run it in a trial. And why the online? Because actually the Australian group had shown that there was better adherence, particularly through COVID. Obviously, didn't want to come in, but that carried on. So people do like doing home-based exercise as long as they've had some guidance. So I think you'll all kind of, say yes to that, because you just want the confidence. A lot of other studies have been self-reporting. So the online program allows you to perhaps put in a tracker or a monitoring device to allow the proper reporting of what actually is being done, so that home-based activities can go on and we can monitor compliance. So I say we had a large group of patients, and we looked at the Physiotech platform. We wanted to understand the barriers, what would make it more accessible to them, and what to include and what not to include. And that was the first phase. And then we produced the video based on their feedback. And then we tried to put that into a grant application, which unfortunately just got rejected. So we'll have to try it. They had various other aspects that the funders didn't like, so we'll probably change that. But essentially, what we found is that the current programs that are available to utilize are poor, because they don't show you through audio what to do. So clearly, patients would have preferred to have a voiceover, simple really, showing them what to do, clarifying how to do it. And actually, as we'll go through, the NHS Living Well site, and I'll direct you towards it, actually has that, and they've really kept that quite quiet. They don't really laud that, but they've put on some really good exercises on that site, and they have a voiceover. So, that's actually, sorry, that's the second slide. This one, where we asked them, were you absolutely clear you wanted a professional? And a lot of them said no. As long as we're clear what we need to do, we don't have to have a professional all the time showing us what to do. We can have another demonstrator who clearly understands. And then I say the voiceover was the second bit. They said, yes, we clearly need a voiceover. So we then put it through to another focus group to say what bits about the video that we'd made they liked and what they didn't like. And then we did a final video, which really incorporated different people from different looks, ages, and these all had simple exercises with a voiceover and very clear instructions guided by a sports scientist. And say different, we put in a man because that's what came back as feedback, and obviously got the demographics a bit better than all these other platforms. So as I said, we really wanted to also look at how we can track things and monitor things going forward. So we've actually, and this is where I need your help, we're actually looking at a tracking device, working with a company, and this would be the tracking device. So it's that big, and it would sit on your skin like it is here, underneath like a little meepaw, and it stays on your skin. It stays there, and it can stay there for 2 weeks with nothing out. You don't need to, and it's waterproof. They don't suggest you can swim with it, but you can shower with it. And the advantages to us is that if we were doing a study, we could track what's actually being done. So if there's an intervention, we can actually see, because that's the problem. It's all been self-reporting to date, and we would really like to actually have some objective evidence of what was done and what is being done and what continues to be done. And it gets changed every 2 weeks. So if you wouldn't mind, Carlo's kindly agreed that I can do this. There is a further another one of those posters out sitting on the table outside next to the Make Seconds Count stand, and there's a little QR code that if you just scan on that, it'll take you to a survey. It's only three or four questions about your views on being tracked. It's not about we're asking you to do it at the moment because it hasn't been validated, but it's just we have to do that. So just quickly, there are people, Can Rehab Trust is where we probably need to access more. This is Anna Campbell's group. They actually have physical therapists in there that can guide other people into physical therapy. And I think we need to access them further. The NHS site, as I said, does have guidance. And you go to the NHS Living Well, Strength and Flexibility, Balance and Sitting. And they have videos of exactly how to do it. And we'll move through that slide. And then Breast Cancer Org. So this has changed. Nobody really had any clear guidance as to what to do. Breast Cancer Org is an American site, but they've updated their website now to have, as from October, clear guidance for advanced breast cancer. So this is what you can do now, whilst hopefully being involved with a national study, if we can get it off the ground. They do adhere to the 150 minutes, which is the standard for all health settings. And they give all the reasons that we've talked about. Reducing the risk of falling, because if you maintain your balance, then you reduce your risk of falling. I think that's really important for advanced breast cancer, is keeping your arm. The reason why you don't fall over when you're young is because you keep your proprioception is sending signals back. As you get older, those signals start to fall. When you get older as a woman, particularly, you do that, and you lose your proprioception. When you get advanced disease, you tend to do that. So all these things are really important to maintain balance. And if you've got bone mets, obviously the last thing you want to do is fall. So I think that's a really important one. And then the other ones you can see are the ones we've talked about. And then think about what exercise is going to do for you. What do you want to gain out of it? And I think the most important thing is strength and endurance, and lessen a side effect. You may have a side effect, and it's mostly fatigue. Fatigue is an important side effect to conquer. And then with somebody, you need to address the barriers to exercise. Have you got some neuropathy? So what exercises are not going to be good for you? And then they give 3 simple things to improve muscular resistance. Sit to stand. It seems really basic, but actually to do it, 3 reps of 10 every day, or 3 times a week, 4 times a week. And start slowly as part of the thing. Sit on the edge of a chair straight for 20 to 30 seconds. Seems really, but that's sitting on the edge, and you have to pull your core. You have to sit up straight. Arm lift with full extension overhead. Seems again. But all these are the ones they've gone through to say, what limited stuff can I do, however advanced my disease is, to just combat that fatigue and improve quality of life. And know the difference between exercise soreness and your pain that you may have intrinsically from your disease. So I think that's, again, another really important piece of advice. And make muscular resistance part of your routine. So this clear drive towards muscular resistance. Start small and work up. However, they have built in very clearly now, because of the International Bone Metastasis Exercise Working Group, alignment and controlled movement. And and there is a bit of hype about this and a bit of neurotic overkill about this. But if you've got bone mets, that need to be taken into account. A physiotherapist should know about it. And this is where we need to train physical therapists to not be neurotic about it, but clearly, if you've got spinal bone metastasis, you don't roll on your spine. Inline activities is what you want to do. You want to do inline activities. So you can squat, you can lunge in one direction. You probably don't want to do too much twisting. So that's what the Safe Fit group adhere to, is what they call inline activity, and that's very easily accessible. And obviously not jumping and not putting weight on the areas where you've got bone metastasis. It's common sense. But we do not want to preclude women with bone metastasis doing exercise. Just, a common sense and advice from, most physicians, because I would quite like to run a training program for physicians. It would take 5 minutes for CNSs and physicians to be able to go through this. And that would be how we in the UK could actually make this doable. So in summary, discuss with your clinician. Can Rehab is a sort of championing website. Lots of talk from it when I phone them to say they will help you locally. Use the NHS videos as simple ways. Implement the Safe Fit policy of bone mets in spine, no twisting, no direct weight on the areas. Move in one plane. And, as I say, no direct weight. Evidence suggests you will definitely improve your quality of life and your toleration of treatment and your fatigue, and we just need to see if there's a further correlation then ongoing with improvement in overall survival and other survival outcomes. So thank you very much.
So I'm grateful. I think that was a really good presentation. What is often seen as unsexy topic, really important. The other issue is just to remind people these are videoed. They'll be on the website. So if you want to give it to your oncologist, if he says, well, you've got bone mets, you can't exercise, you can say, Dr. Harper-Wynne said, here's the video and the slides. So please use the resource to educate other people, and particularly if you have got clinicians who are a bit worried about bone mets and exercise, you've just heard from one of the experts, probably one of the best experts in the UK around exercise and breast cancer you've got in front of you. So open to questions. We're running a bit behind time. Lady at the back, so we have 2 or 3.
Your body composition currently is. So where are you in terms of lean mass?
Well, there are, a lot of there is some of the standard physical trainers in gyms have a machine that is pretty much like a DEXA and will work out your BMI and your lean body mass. You can get it out of a DEXA scan if you wanted to, but whether the NHS would allow you to use that resource. But a lot of gyms do have this machine which is equivalent of a very low X-ray use, and it will work out your lean body mass. There is a calculation you can do as well from your BMI and various other ways of doing it, which you can get out. But you could also ask them to look at your psoas width, scan to scan.
I've had sort of mixed responses to certain types of exercise, whether it's okay to do it if you've got some mets in your spine. One of them was running. I jog, I couldn't say run, but not very far, and I've always done it. I'm pretty fit. so I can do it. And some people have told me you shouldn't be doing it, but my oncologist said it's fine to do it.
Yeah, I mean, I think, this is where it's like, the panic, the scary.
Yeah.
I mean, the thing about, it's all about your musculature around your spine. So the reason to say no is that because you're on therapy, because you've got cancer, you've got a wasting of your muscles adjacent to the spine. So the spine is inherently unstable anyway. I mean, not just in relative terms, and that's the concern. But if you are trying to do some exercise that actually builds up your spinal muscles, which squats will do, which sitting to standing will do, there are lots of exercises that will keep your strength, then I can't see personally that running is an issue, but you must maintaining your muscular structure, which is the same for everybody, to be honest.
You said about asking to see your what was the back muscle called? Psoas.
Yeah.
So I can just say.
Well, you could. I mean, it's a bit cheeky because no one will have a clue what you're talking about.
No.
I mean, this is the kind of thing. If you had somebody that was interested in your area, that could be a way. If you had embarked on a program and you wanted to know, I mean, say gyms will do your lean body mass, and you can probably get your lean body mass done. It's not a huge amount of money, but all of this is there's no concerted approach. If you've got somebody in your area, whatever hospital you're in, whatever region you're in, that is trying to champion exercise, or maybe your local groups. I mean, we have a breast cancer now group for advanced breast cancer, and we're trying to champion these things. And I think probably as patients championing it through that forum, and then getting an interested clinician who's prepared to actually look up some of the stuff about it, or a BCN that's prepared to look up, breast cancer nurse who's prepared to look up stuff. That's the way we're going to move things forward.
Okay.
Dare I say, as an individual patient, it's going to be really hard. But I would speak to your local group and say, look, this is something we want to take forward.
Great.
Somebody's going to walk into a consultant next week and say,
Thank you.
Can you measure my psoas? Where have you heard that? Who have you been talking to? That's the beauty of this meeting.
It's the name of a muscle. It's a big fat muscle down your back.
Yeah, just the name of a muscle.
And that comes up in a CT scan.
You can see it's one that can be measured. It's a good one that can be measured.
It's a chunky one.